It's time for the 3-question warm-up for Gynecology 1. Let's get going. First question here, anti-centromere antibodies are associated with what condition? Remember, that's going to be crest scleroderma. Next, what blistering skin disease has a positive Nikolsky sign? So positive Nikolsky sign is pemphigus vulgaris. Next, which blood cell pathology matches the following high-yield description? So first we have associated with Epstein-Barr virus, and especially in Africa, that's going to be Burkitt lymphoma. Reed-Sternberg cell, cervical lymphadenopathy, night sweats is going to be associated with Hodgkin lymphoma. Bence-Jones proteins, osteolytic lesions, high calcium, that's going to be multiple myeloma, and that's going to secrete that local osteolytic factors that are going to break down that bone. Translocation 14-18, that's going to be follicular lymphoma. Most common lymphoma in the United States is diffuse large B-cell lymphoma. Translocation of the 8-14, that's going to be Burkitt lymphoma. Translocation 9-22, this is going to be the Philadelphia chromosome, which is mainly seen in CML, but about 15% of adult ALLs also have this translocation. And very rarely, AML can have this as well, but the main one to remember is CML, because CML always has the Philadelphia chromosome. The most common form of Hodgkin lymphoma, that's going to be nodular sclerosis. Starry sky pattern, and this is due to the phagocytosis of the apoptotic tumor cells, that's going to be Burkitt lymphoma. High hematocrit and hemoglobin, pruritus, especially after a hot bath or shower, burning pain in hands and feet, that's going to be polycythemia vera. All right, that's going to be it for the warm-up. Let's get to that video now.
Hello, and welcome to this episode of Dr. McInnes proving his manliness by wearing a purple shirt. In this video, we're kicking off the gynecology section, which starts on page 239. Now, most of us tend to lump gynecology and obstetrics together in our minds, but in Step Up, these are actually two separate chapters. So let's start gynecology with some normal stuff. We're going to start with normal gynecologic development because you have to know what's normal before you can really understand abnormal. So when we're talking about gynecological development, we're talking about puberty, right? And puberty is hormone driven. You've got changes in FSH and LH and estrogen. So if you look at figure 11-1 on the next page, don't worry about the levels on the left in utero. Just look over here on the right side. Around age 8, the FSH starts to rise. And then a couple of years later, the LH starts to rise. And then a couple of years after that, the estradiol level rises. Now, I don't know that it's terribly important to know the ages where they start to rise or which hormones rise first, although you could probably make an educated guess that FSH and LH have to rise before estrogen does. I mean, estrogen comes from the ovaries or gonads primarily, and FSH and LH are the gonadotropins. So without that rise in FSH and LH, the ovaries won't make estradiol, and estradiol won't rise. But back on page 239, if you look at this table, you can see that somewhere between 8 and 11, the LH and FSH and androgen levels start to increase. And it says this is what kicks off the initial pubertal changes. Now, up in the text, number 2 says that secondary sexual characteristics are caused by androgens. That's not to say that estrogens aren't important as well, but androgens are very, very important for this, even in women. So what kinds of changes are we talking about in puberty? Well, there's a well-defined order of events in normal female puberty, which you can see in the quick hit. The first event is called adrenarche, which is adrenal androgen production. That's DHEA primarily. Now, I didn't point that out, but that's actually the first thing to rise if you look back at that hormone diagram on the next page. Next is gonadarche, which is activation of the gonads or the ovaries by FSH and LH. So we're already 2 stages in before anything outward is going on. So the next one is telarche, or the appearance of breast tissue. We're going to look at the steps in breast development in just a second. And then you have pubarche, which is the appearance of pubic hair, then the growth spurt, then menarche, or the onset of menses. So menstruation is the last new thing to happen during puberty, and it happens on average around age 13. Now look at the quick hit toward the top of the page. The mean age of menarche is 13 years of age in the U.S., and it tends to occur earlier in blacks than in whites. It's also earlier in Hispanics or Latinas than in white. Now, even after menarche, puberty isn't finished. There's still breast development going on, pubic hair development, and all those other things going on. So let's go back to page 240 and look at this table for the Tanner stages. Now, Tanner staging is a 5-step staging system to look at the different advancements through puberty. The 2 big ones that you may be tested on are going to be breast development and pubic hair development. Now, there are also some Tanner stages for boys, which have to do with the development of the testes and the penis and the pubic hair again. But let's look at the Tanner stages for girls. It's really a lot easier than you might think at first. Again, we're ignoring the male development. Stage 1 is prepubertal. So these are the childhood stages. You know what childhood genitalia look like. And then stage 5 is a mature adult stage. And I imagine you know what that looks like too. Then stage 3 is really sort of indistinct. It's this, it's further breast development. It's further growth of hair. That's not too helpful on its own. So you really just need to learn what stage 2 looks like and what stage 4 looks like. And we're going to focus first on breast development. So the one thing I want you to notice about stage 5 for breast development is the mature breast is defined by the areola receding to the level of the rest of the breast, so that only the papilla, or the nipple, projects above the surface of the breast. So stage 1 is the childhood stage, and stage 2 is breast budding, with development of what are called breast buds, just slight elevation of breast tissue above the surface of the chest, a little bit of breast tissue, a little bit of nipple above the surface of the chest. And also you have areolar enlargement, so that the areola is larger in diameter than it was back in the childhood stage, stage 1. So breast budding, again, is called telarchy. It's that first onset of breast development. And the average age of telarchy in Caucasian girls is about 10 and a half. For Latina girls, it's about 10 years. And for black girls, it's 9.5 years of age. Then stage 3 is just defined as further breast enlargement on the way to stage 4, which is where the breast is basically fully formed, but the important distinction is that the areola remains elevated above the level of the breast. Then again, stage 5 is where the areola has receded and only the nipple is elevated. Then look at pubic hair development. So for pubic hair development, again, stage 1 is no hair, or just that fine, non-pigmented hair like you would find on the body of a child. Stage 2 is the beginnings of some pubic hair growth. The hair is a little longer, it's starting to be a little darker, a little pigmented. Stage 3 is just further hair growth, and it's going to be a little more coarse, a little curlier. Stage 4 is where the hair spreads over much of the pubic region. But the distinction is that it does not spread to the thighs in stage 4. That would be stage 5, when the pubic hair extends to the medial thigh. And that's what defines mature adult pubic hair growth. So if you were going to be tested on this, the question would have to say whether or not the pubic hair extends to the medial thigh. So that's sort of an important distinction to make for testing. Now, in practice, tanner staging based on pubic hair is essentially impossible because of grooming and waxing and shaving and so on. I had a professor in med school who said, I never see tanner stage 4 or 5 in adolescence, so make of that what you will. All right, let's move on to precocious puberty, which is the development of pubertal changes in girls under 8. Now, the quick hit reminds us that precocious puberty in boys occurs under the age of 9, and is most commonly caused by adrenal hyperplasia. Now, there are 3 main groupings or categories of precocious puberty that can help you make some sense of all this. The first and most common is familial and genetic causes. So basically, mom started puberty at 7.5, and grandma started puberty at 7.5, so your patient's going to start puberty at 7.5. It's just normal for that patient. It's just genetics, even though it gets defined technically as precocious puberty because it's before 8. Then the other 2 categories of precocious puberty are going to be pathologic. So the first of those we call central or true precocious puberty, and then the other one is pseudo-precocious puberty. So if you look at number 2 and step up, it says that precocious puberty starts because of early activation of the hypothalamic pituitary gonadal axis, which would be central precocious puberty, or because of autonomous excess secretion of sex steroids, which is that pseudo-precocious puberty. Now, this could be further broken down into heterosexual or isosexual precocious puberty. So isosexual is where there's premature sexual development that's appropriate for the patient's gender. So this just means that a little girl is developing normal female characteristics. She's just doing it way too early. Then heterosexual precocious puberty is where you're developing in a way that's more like the opposite sex. So in girls, that would mean virilization or masculinization of girls. That usually results from congenital adrenal hyperplasia or exposure to exogenous androgens, or there's an androgen-secreting neoplasm. So heterosexual precocious puberty is always going to be pseudo-precocious puberty. And by definition, you're not following that normal axis. In boys, heterosexual precocious puberty would mean feminization, like gynecomastia or breast development. And obviously, excess estrogens are going to stimulate that. Now, in the margin, the second quick hit says that CNS lesions, that's a typo, change that CM lesions to CNS lesions. So CNS lesions or trauma would be a cause of isosexual precocious puberty in about 10% of cases. So remember, isosexual is where they're developing appropriately for their gender just early. Then isosexual precocious puberty can be characterized as either complete or incomplete. So complete is when all of the sexual characteristics develop prematurely, and then incomplete would be when only one of those characteristics develops prematurely. Next, let's look at this section on the labs. Now, This is a little confusing, but I want you to notice none of this is bolded. I want you to try to understand this, but it's not going to be particularly high yield for your test. So if you have high LH and high FSH, and you give more GnRH, so the FSH and the LH are then going to go up even more, that would suggest central precocious puberty. So there's something going on in the hypothalamus to release extra GnRH, and then the pituitary and the gonads are just responding appropriately to that extra stimulation by excess GnRH. So the GnRH is what's driving the whole thing, and because that GnRH is high, FSH and LH are high, and then the sex steroids from the ovaries are high. The next part at the very bottom of 240 is basically pseudo-precocious puberty. So you have low LH and low FSH, and when you give a little extra GnRH to stimulate the pituitary, it doesn't put out any more LH or FSH. That's because there's already so much negative feedback coming to the pituitary from those excess androgens or estrogens. And LH and FSH and GnRH are basically shut down. So even if you give them GnRH, they're still not going to increase those gonadotropins. Then at the top of 241, I think letter B is kind of worded in a confusing way. If they have increased estrogen in the presence of low LH and FSH, that suggests endogenous hormone production independent of the hypothalamic pituitary gonadal axis, like from a neoplasm that's producing estrogen, or possibly consumption of exogenous estrogen. So they have high estrogen, but it's not controlled by that LH and FSH. It's coming from somewhere else. So high levels of adrenal steroids can be seen with neoplasm or congenital adrenal hyperplasia as well. And we mentioned back in endocrinology that DHEAS is the androgen that is only produced by the adrenals. So if you're testing for ovary-derived testosterone or ovary-derived androgens, you could look for overall testosterone. But if you want to know if it's coming from the adrenals, you need to look for DHEAS. And then finally, letter C talks about how hypothyroidism can cause precocious puberty as well. So the thinking is that if you have high TSH, which you see in hypothyroidism, that TSH can actually stimulate the LH and FSH receptors because TSH and LH and FSH all share an identical alpha subunit. So if you see high TSH and low T3 and T4, that could certainly be the cause of precocious puberty. And again, if all that lab work got your head spinning, don't panic. It's probably not going to be super important for you to memorize. Next, let's look at radiology. If we think that this is central precocious puberty, we may want to image the head with a CAT scan or an MRI to look for some sort of lesion. If we think this is pseudo-precocious puberty, we can image the abdomen with ultrasound or with a CAT scan as well to look for either an adrenal tumor or an ovarian tumor. And then finally for treatment. If it's central precocious puberty, we can use a GnRH analog that's going to suppress LH and FSH. Remember, we have to give this a special way. We have to give it as a continuous dose. If you were to give pulsatile GnRH, it's going to reproduce what the GnRH is doing naturally. It's actually going to stimulate FSH and LH. But GnRH that's given continuously will suppress the gonadotropins. And then if we think this is due to an ectopic hormone secretion by a tumor somewhere, you would want to remove that tumor surgically. If we think something like congenital adrenal hyperplasia is going on, you're going to give cortisol replacement. So remember, with congenital adrenal hyperplasia, one of those enzymes is deficient, and you get both decreased production of cortisol, plus everything is shunted over to the right, you can have excess sex steroid production. So if we replace the cortisol, the adrenal gland will kind of shut off. Now really, you don't always have to treat precocious puberty. For instance, if this is happening close to the expected start of puberty, you don't have to give any treatment. If they're just a couple of months ahead of schedule, delaying it isn't all that necessary. If they're having incomplete precocious puberty with just, say, breast development, you want to rule out any serious pathology, but otherwise you can just kind of observe the patient, make sure she's not going to end up with complete precocious puberty. And then for complications, you can have physically short stature because the hormone release is going to cause some fusion of the epiphyses in the bones. And then you can also have social and emotional adjustment issues. For instance, if you have a 6-year-old girl who's gone through puberty, she's going to be very distinctly different from her classmates, and that can cause some emotional problems. Then the next section here is on the normal menstrual cycle. So let's look at figure 11-2, which is on the next page. And I'm sure you've seen this before. And if you're honest with yourself, it probably still gives you the heebie-jeebies. But this is really not that hard to grasp if you just kind of break it down. Now, the first thing I want you to notice is that there are two phases. There's the follicular phase, or proliferative phase, and then the luteal phase, or secretory phase. And then the event that separates these two phases is ovulation. So the follicular phase is where you have the growth of the follicle in the ovary, which is driven by FSH. So which gonadotropin stimulates the follicle in the follicular phase? Follicle stimulating hormone. I told you this wasn't hard. And the FSH is stimulating the follicle to produce estrogen. This is also called the proliferative phase because the endometrium is proliferating and getting thicker so that it's all ready to go in case fertilization and implantation take place. And then you get this massive surge of luteinizing hormone that results in ovulation, and what's left of the follicle becomes luteinized, and we call it a corpus luteum. So this is the luteal phase. And the corpus luteum makes progesterone, which is progestation. So progesterone is a hormone that keeps that endometrial lining nice and thick to support a potential implanted pregnancy. So the luteal phase is LH and progesterone dominant, while the follicular phase was FSH and estrogen dominant. Then toward the end of the cycle, the corpus luteum degenerates and quits producing progesterone, and when that happens, there's nothing to maintain all that thick endometrium, so it starts to slough off, and that's menstruation. But if pregnancy and implantation had taken place, the embryo produces HCG, which is going to help keep the corpus luteum going longer, and that's going to keep producing progesterone until the placenta can develop and start producing its own progesterone to support the endometrium. And then notice at the bottom, basal body temperature jumps up about half a point right around the time of ovulation. Now, I also want to put out two important concepts. First, menstruation is triggered not by the presence of a particular hormone, but by the absence of a hormone. It's the withdrawal of progesterone that causes menstruation. And then second, this withdrawal of progesterone always occurs about 13 or 14 days after ovulation. That timing from ovulation to menstruation doesn't really vary. So if under normal circumstances the follicular phase is 14 days and ovulation occurs, and then 14 days after that the corpus luteum shuts down and progesterone production shuts down, and you're going to have this nice regular 28-day cycle, 14 before ovulation, 14 after ovulation. But say you have an abnormally long cycle, say you have a 6-week cycle, a 42-day cycle, then the way it breaks down is you have 4 weeks of estrogen building up, 4 weeks of that proliferative phase, then ovulation, and then the luteal phase is still just 14 days long. It's pretty predictably 2 weeks long. So to finish up this section, let's flip over to table 11-3, which is the top of page 243. Now this is just a quick summary of the key hormones, and the highlights for you are in bold. So luteinizing hormone, or LH, has that mid-cycle surge, which induces ovulation. FSH stimulates development of the ovarian follicle. Estrogens stimulate endometrial proliferation. They aid in follicle growth. They induce that LH surge. And then high levels of estrogen actually inhibit further FSH secretion. Progesterone, we said, was progestation. So it stimulates endometrial gland development. It inhibits uterine contraction. It increases the thickness of the cervical mucus to protect the pregnancy inside the uterus, keeping infection out. It increases basal body temperature, and it inhibits LH and FSH secretion. And then star this last one. A decrease in progesterone is what leads to menstruation. So we can simulate that if we want to give a woman a period for some reason by giving her 10 or 15 days of progesterone and then stopping it, and that's going to induce menstruation. And then finally, HCG maintains the corpus luteum and progesterone secretion. So that's it for menstrual physiology. Now we're going to go over this rather enormous end of session quiz. Now it's really not that bad, it just looks long. All right, first question. What's the mean age of menarche in the US? Well, it's 13. Next, what's the definition of precocious puberty? So pubertal changes before 8 years of age in a girl would be precocious puberty, or before 9 years of age in a boy. Next, what lab findings distinguish true precocious puberty from pseudo-precocious puberty? So again, in true precocious puberty or central precocious puberty, you have high LH and high FSH, and when you give that GnRH, it's going to increase FSH further. In pseudo-precocious puberty, you have low LH and low FSH, and there's no response when you give that GnRH. Next, what are some of the causes of pseudo-precocious puberty? It can be caused by exogenous hormones, adrenal tumors or other hormone-secreting tumors, and then again, congenital adrenal hyperplasia. Next, what's the treatment for central precocious puberty? We're going to give continuous GnRH analogs to induce a menopausal state. Next, which phase of the menstrual cycle is fixed at 14 days regardless of cycle length? That's the luteal phase. And the next one, FSH triggers the release of which hormone from the follicle? That's estradiol. All right, that's it for Gynecology 1. Now, in the next video, we're going to talk about menopause. I'll see you then.